Thank you very much and welcome everybody who's joined us for this webcast to talk about coronavirus. My name is David Levy. I'm the CEO of EHE Health. As you know, for our clients for many years, we here have a program at EHE Health where we take care of your beneficiaries' preventive health and primary care needs. But in addition, we take our public health responsibility very seriously with respect to helping translate what's going on in the public health environment. Every year we send out an annualized approximately 1 million public health notifications, whether that's for measles epidemics, vaping, or whatever. And we have been challenged with this coronavirus epidemic and having had multiple questions and discussions with many of you who are on this webcast today. So as a result and in consequence, we've decided to put together a group of national, international experts to create a panel to talk to you about what they are seeing on the ground and some recommendations. And we're delighted to be able to offer this to all of you. Today we have three phenomenal panelists who've agreed to join. Dr. Ian Lipkin, the John Snow Professor of Epidemiology at the Mailman School of Public Health at Columbia University. He is an internationally recognized authority on viral outbreaks, and he was the chief scientific consultant for the movie Contagion. Dr. Bernard, he is in isolation, and you'll see him on a different screen when he speaks. He will not tell us from where he's in isolation, but I know that it's in the U.S. somewhere. Dr. Bernard Camins is here. He's the professor of medicine and infectious disease and the director of prevention at the Mount Sinai Health System in New York City. He will be talking to us about the provider response to the epidemic. And Ms. Gail Russell, who was a founding member of the International Society of Travel Medicine and the recipient of the 2017 Distinguished Nurse Leader Award from Cornell, the New York Hospital School of Nursing, and the Mailman School of Public Health in New York City at Columbia University. Each of our panelists will give a 5 to 7 minute introduction on various aspects of the epidemic. Then I'll ask them each 1 or 2 questions, and then we will go into an open forum where we would ask you to type in your questions. They can be anonymous or non-anonymous, and I will read out the questions to the individual panelists, and then we will close the discussion towards the end of, we've timed this for 90 minutes. If we end sooner, that's just fine as well. So thank you again, and welcome to the panelists. And right now I'm going to introduce Dr. Ian Lipkin.
Now it says I'm muted now. Can you hear me?
You're good.
We can hear you.
You're all good.
Well, I apologize for the some of the difficulties in transmission. First of all, I appreciate the opportunity to speak to you because obviously this gives us a great deal of reach, because what we communicate to you will thereby go to other people and will have a larger impact. My focus during the course of these brief remarks is going to be on what we know about the outbreak, what I learned in China prior to returning last week, and during the Q&A period, if there are any questions you want to pass about transmission, fomites, what we know about the trajectory of the outbreak, diagnostics, I will be happy to try to be helpful. I'm not really going to dwell on the numbers. As everybody knows, they are very, very high and climbing, and whatever I tell you today will be inaccurate tomorrow. The numbers that you're reading about the newspaper are lagging by at least 5,000 in count, in countries and in mortality. So let's just talk about some basic principles. This virus, as we learn more about morbidity and mortality, is not as great a risk, we think, to the population globally as is flu. So in any given year, globally, we have 350 to 650,000 deaths. I don't think that we're going to get anywhere near that with this virus. But then again, a third of the population probably won't become infected with this coronavirus. The current estimates that you will hear about mortality are in the neighborhood of 2%. This figure does not take into account those people who don't come to medical attention. As we begin to collect antibody data and identify those individuals who've been infected who have not come to the attention of the healthcare system, I guess, and I'm not even going to say speculate, my guess is that it's going to be a fraction of 1% probably somewhere in the same range as seasonal flu. That said, it is a new virus. It is very well adapted to growth in humans. I'll talk about that in a moment. And we don't really know what it's going to do. So there's a lot of uncertainty, and this is part of the reason for caution and concern. The original thought was that this began in a seafood market in Wuhan, China. The seafood market was more than a seafood market. They sold all sorts of animals, ranging from small mammals to birds and bats and such. The evidence to support that is limited because when people went in and tried to collect specimens, they were all gone. Environmental sampling revealed the presence of nucleic acid signatures for this virus in sewers and cages, but that's really all we can say. And it is equally plausible that this virus emerged in humans before anything related to this market. So we speculate that the market was important, and we are concerned about markets because wild animal markets are a risk, but we don't really know where this virus originated. Some people think it originated in Beijing. Most people think it originated in Hubei province. What we do know is that the virus is, on a genetic level, most closely related to viruses that have been identified in bats. There's some recent data that will be coming out in manuscript form shortly that shows that there's a very small animal called a pangolin, which has sort of related to an armadillo, in which there are very similar sequences as well. And some people are positing that this might be the intermediate for the virus. The virus is extremely well adapted. It binds to receptors in the respiratory tract of humans, and in most cases, probably very mild illness, like a common cold. In people who are immunosuppressed, who get very large doses of virus, it becomes very different. You get a classic viral pneumonia, cytokine elevations, and we don't yet know much about the pathology because, to my knowledge, we have yet to have a single postmortem exam. But I expect it to look fairly similar to what we saw with SARS in 2003. The impact of this virus and this disease in China looks very similar to what I saw in 2003 when I was in Beijing. The streets are deserted. People are rarely venturing out to get the necessities of daily life, and everything is coming to a close because people are afraid to congregate and go to work. What we know about transmission at present is that the majority of it, the vast majority of it, is human to human. Most of that is by aerosol transmission. We don't yet have any good studies of fomites. If we think in terms of what's known about SARS, that virus is no longer viable after 72 hours on a smooth surface. I predict that we will find something similar with this. So it's not as infectious, for example, as a norovirus or a measles virus for that matter, but it is still very infectious. With the SARS coronavirus, there was shedding of infectious material in feces. And over the past 24, 48 hours, you will have read reports about apartment complexes and office complexes where people have been exposed and become infected. And I presume that what happened here is that this came about through pipes and such, because many of the pipes we see in some of these parts of Asia don't have the classic sort of U-trap that keeps vapor down below in the sewer where it's supposed to be. So instead it comes up as an aerosol and people become infected by inhaling particles that are present in that way. We anticipate that as the temperature goes up, that the viral particle size will become larger, they'll become heavier, and transmission will be adversely impacted. On to diagnostics. The only diagnostics we have at present have been developed by 2 or 3 groups. They're unfortunately not as sensitive as we wish they were. So there are people who present with classical signs and symptoms of disease who are negative. One explanation for this is that the virus may be deep in the respiratory tract. Another possibility is that they're not appropriately sampled. And the third is that there's a problem with the assay. There are so many assays being run and such a run on equipment and supplies that quality control is another challenge. In terms of sequences, is the virus changing? The virus is already very well adapted to humans. I don't see much in the way of selective pressure to make it change, but it may well do so. We're exploring a number of drugs that may or may not have activity. I think it's likely that this virus will stay with us and will become endemic and global and will recur on an annual basis. So there's a major effort underway to build vaccines of various types. We can go into those in more detail if you wish. But I think in terms of an overview, I would say that this is an important new virus. It's not likely to be contained. It isn't contained. It's already in more than 28 countries. We have it here in the United States. I don't think you can erect a wall on the border with Mexico, even if they pay for it, that's going to keep it. Thank you.
Okay. Thank you very much, Dr. Lipkin. Dr. Camins?
Thank you for that introduction as well. And yeah, and I think it bears restating, right? While the novel coronavirus remains a public health threat, we actually have more issues with the flu currently this winter, right? I think more than 10,000 people have already died this year, and 68 of them were kids. So that said, what is our response in the US have been? So the public health agencies are always reminding us that we should then identify, isolate, and then inform, right? By that we mean I prepared our facilities within the Sinai Health System to actually ask patients about their travel history. We've been doing that since Ebola. And then we ask symptoms that are consistent with infectious diseases. And once they have said yes to a travel history and symptoms, we then tell them to isolate the patient and then get more information to call infection prevention and our public health partners to then figure out how to what to do next, right? So the CDC gives us guidance. In fact, they have a call almost every week. And our DOH, Department of Health for the city, Department of Health and Mental Hygiene, and also the New York State Department of Health have also been very helpful with giving us weekly updates as well. So what do you do if you return from an endemic area? Right now, based on a presidential proclamation, anyone who traveled to Hubei province within the last 14 days will be quarantined, and this will be mandatory quarantine to be chosen by our government. If you did travel to mainland China the last 14 days, you will then have to be on self-quarantine, likely at home, and then also do self-monitoring, and that would entail taking your temperature twice a day and reporting your symptoms if you do develop symptoms. Now, at least from the update yesterday, the Department of Health have said that they will actually give contact information for people returning who are on self-quarantine or self-monitoring that then you can call if you do start having symptoms. And then at that time, with the public health official, their recommendation, you could then go to either an urgent care clinic, a primary care clinic, or even the ER, depending on your symptoms, preferably something affiliated with a larger medical center, and to call them ahead, right? And then you would tell them to say that I am having symptoms and I just traveled to mainland China, and ask for a surgical mask, because that would then help us prevent from spreading the virus. As Dr. Lipkin mentioned, testing, at least in the US, testing currently is only available in the CDC, but I think today, Illinois State lab has started doing their own tests, and at least from the update yesterday from the New York State Health Department, is that they are actually doing the validation studies to be able to do the testing as well at the local, at the state level. I doubt that we will see commercially available tests for a while, and so it will be very hard to actually do these tests. And who would they test, right? So based on the CDC recommendations, the people they think that have the highest risk are then people who have been exposed to patients with laboratory confirmed novel coronavirus infection. So meaning they would have a PCR that was already positive, and then if you were a close contact, you developed symptoms or a fever, then you would be tested. If you were in Hubei province, you have to have fever and symptoms and would have traveled within the last 14 days. And then for anyone who traveled to mainland China, the only people they will test are people who develop fevers and symptoms and have to be hospitalized. Because I think the issue is that if you're actually well enough, you're on self-quarantine anyway, that would reduce the number of testing that they can do, because right now, unfortunately, it's very hard to do all those testing. Regarding mask, right, so there are some questions about, do I need an N95 respirator, which then filters out 95% of particulates, or do I just need a surgical mask? It's a definite no for N95. Those are only really used in healthcare. Number one, you actually have to go through something called fit testing, meaning does the mask really fit your face? There are different brands. So in our institution, we pick a certain brand, but for 5% of our employees, they may actually not fit that brand, that we ended up giving them an alternative mask. So not all of them are made equally, and that you really, to get a perfect fit for it to work, you need to be fit tested. So just the general public and will not be effective. The other thing is, someone who's worn it a lot, being an infectious diseases physician, I can probably stand it for 15 minutes at the most. Otherwise, I start having trouble breathing because it is very suffocating. So it's not really practical to walk around all day with that type of mask. How about the surgical mask or the face mask, the one that just goes over your mouth and nose? It's really more effective for people who are sick to wear them. That is really what it's more, really where it would help. Now, it doesn't mean that we don't use it in healthcare. If I saw a flu patient, I would actually put it on when I go see them because I am within 3 feet. And at least for this novel coronavirus, they are saying that close contact, because we still don't know, is within 6 feet. So in that situation, then if you are going to be that close to a person who is infected, maybe wearing the mask, face mask will help you. But again, wearing it in public will not really be of any use to you. We do recommend it if you do have symptoms, either the flu or any other respiratory illness, to wear the mask so you don't infect other people. So what should we do, or what do we recommend that you should do to prevent respiratory viruses in general? Well, I think we should ask your employees to stay home if they are sick for any respiratory illness, right, including the flu. If a household member is ill, then they should then cover their mouth and or nose with tissue if they sneeze into the tissue or the sleeve, and wipe down surfaces regularly with a disinfectant. Any commercially available disinfectant is fine. Perform hand hygiene with alcohol-based hand. I took out the label, but I have this because I take the subway and I use it all the time. But if soap and water is available, that is actually the better method of hand hygiene. Avoid close contact with unprotected close contact with anyone with flu-like symptoms. So stay away at least 6 feet, right? And then so you won't be sick. And then the last part is really hard because as human beings, we do this a lot, is avoid touching your face. So don't touch your nose, your mouth, and your eyes if you can. And that would really go a long way in terms of avoiding the flu or even the novel coronavirus if it does come.
Thank you very much. Ms. Russell?
Yes, good afternoon. I'm Gail Russell. I'm a travel health nurse specialist, and I'm certified in occupational health. And this afternoon, both of the panelists so far have talked to you about the coronavirus global emergency. I actually am participating because I'm very concerned about a different epidemic. The World Health Organization and the New York Times have called it an infodemic. We are already seeing myths, misinformation, disinformation, wild rumors, all sorts of suggestions for treatments and therapies on the internet. And I want to share with you 3 points that I feel are very critical for human resources, for the employee health services, for your EAP at this time. The first is that employees need consistent, anticipatory, proactive messages to promote trust, calm, and confidence. Whether they ask you questions or not, they have them. If they're reading the morning paper, they're going to have questions this afternoon about what they see. Dr. Camins just explained the role of the masks. Every picture out there shows people wearing masks. So they're going to say, why are you not providing masks? It is critical that this information be consistent across the company. And so you need to be sure that all the stakeholders, including the cleaning services, people are going to start saying, you know, what kind of disinfectant are you using on my desk? How often should I disinfect my computer? Somebody has a phone that we use in common. Keep in mind that all of these messages may have very personal implications, not necessarily even work site related. People are concerned for their families, they're concerned for their neighbors, they're concerned for their children. Anticipate that any question, given what is unknown about this, and so much is still unknown, is really an important, valuable question that needs a proactive response. Keep in mind that the language of these responses need to be in lay terms. I'm not sure a lot of your employees know what fomites are. I'm not sure they know what persons under investigation is. I'm not sure they even know what a coronavirus implies. Any term that you use should be translated into terminology that every employee and family member can understand. Additionally, all messages need to be considered in a segmented fashion. You've got different travelers. You've got individuals who travel, you've got individuals who work with travelers, you've got individuals who are, I like to call the worried well, anything in the headlines they think they have. You've got individuals who will have symptoms. It's got to be reasonable that they have a resource to go to. My understanding is EHE. Dr. Levy's going to share some of those resources with you at the end of this presentation. Everyone should be encouraged to ask those questions and to feel comfortable raising concerns. Otherwise, you're going to start to see absences, requests for telecommuting, individuals who are going to not, they're going to say, is 6 feet enough for social distancing, or should it be 12 feet? Or should I not be in an open office at all? So messaging is very critical at this time. For your travelers, this is difficult, all right? It's not just travelers to China anymore. That was last week. Now it's travelers anywhere. I have already gotten requests for lists of every airline that doesn't still have flights going to China, so that if somebody is traveling domestically, they don't end up on a plane even going to Toledo. This is going to evolve. This is going to change, certainly daily, but maybe even hourly. So anticipate some questions. Is this a business trip that is critical? Is there an alternative through virtual meetings? Is it realistic for someone to telecommute? Is it realistic to postpone attendance at a meeting? Anticipate that any of these questions, I've had people ask, well, do I have to sit 4 rows ahead of somebody who's coughing, or is 2 rows okay? No question should be seen as out of place given the unknowns. And then finally, every employee should know what the resources are that they can go to. Authoritative resources, science-based resources, resources that are readily available 24/7, weekends and nights, so that if a mother says, I'm afraid you're going into the office, what's going to happen if you come home and are sick? No one should have to get the answers without knowing the authoritative standards that are available. Now, the CDC is out there, but EHE is going to make some available to you as well. And again, frequent messaging, the word is even being used as aggressive messaging. I believe that will help us with this second so-called infodemic, so it doesn't get out of hand.
Well, thank you very much, all three of you. I'd like to just start by asking a question to each of you, and then we're going to open it up for outside questions. There's a button at the bottom of your screens. Just you can type in. I'm sorry?
The Q&A.
The QA question. There's a Q button at the bottom. You can type it in anonymously, or you can identify yourself. It's up to you, and we'll start to take those questions. But first, I want to go to Dr. Lipkin. In our conversations, you mentioned that despite what we hear in America, that you feel that the Chinese authorities have been doing a pretty good job of transparency and control. And maybe you can make a few comments on that to allay some of the fears. But that being said, obviously, the world is porous. We have a huge number of cases, obviously, in China. I think almost no fatalities anywhere else. How do you see this thing rolling out in the next weeks and 2 or 3 months? And when do you think it peaks? And when do you think that the fear abates and the spread abates?
The first question, which has to do with are people sharing data? The answer there, I think, is they're sharing what they have. This is a this is a country, 1.3 billion people. And there's a vision that we have on this side where it's monolithic and everybody knows what's going on in the west of China, in the north of China, in areas, frankly, that are very poorly served with healthcare, and monitoring is challenging. We do know that the sequences were released more rapidly than they were during SARS, and we are getting the daily counts are obviously behind the curve, but you can imagine if it's in every province in China, just as it would be if we were trying to get data on morbidity and mortality from every state in the United States and every province in Canada, which would still be smaller than what they have to address, it's very difficult for them to be accurate. I don't think there's any deliberate obfuscation. Does that mean we have complete case ascertainment? No. Does that mean we know about all the deaths? No. We have approximations that represent the best that their healthcare system can offer, and there are challenges with their healthcare system. Their PCR assays, for the most part, are not yet fully validated by the China FDA. They vary. Methods that are used for counting people also vary. They have come light years since where they were in 2003 when I went during SARS. So things are much, much better. But we don't have a complete picture, and neither do they. Now, with respect to where is it going, I alluded to the fact that as we move into warmer weather, that there will be changes in the characteristics of viral particles that we predict will have an impact on how far these particles can fly. If they're denser and heavier, they're just not going to travel as far. Now, I base this largely on comparison to work that was done by one of my colleagues at Mount Sinai, Peter Palese, who studied this with a ferret model with influenza. And there was temperature and humidity played important roles. The warmer the air, the more humidity you can absorb in the particles, the denser they are, the less far they fly. I've been telling the Chinese government that I think, that I thought, because we initially had these conversations, people were saying the epidemic is going to peak the second week of February. I said, I'd be very surprised if that were the case. I'm thinking more like April. And if we have warmer weather, in a sooner period of time, then we may well see it begins to peak and drop. If you look at what's happened over the past few days, there has been a drop in the number of cases reported. This is challenging because the definition of cases changed. Cases used to include anyone who was PCR positive, even with all the caveats about how good that assay is. Now, to be a case, you have to have PCR positive findings and have symptoms of disease. So I don't think it's obfuscation. They define it as such. It's just that people are so stretched. If you can imagine what it's like in Hubei or Wuhan, where you had these big pockets where people wind up becoming ill, there are two explanations. One is that they're tired, and when you're tired, you make mistakes. The other thing is that aggressive pulmonary toilet gives you more aerosols. We saw this in 2003 in Hanoi, where there were two hospitals. One, the French hospital, the private hospital, where they had a very good respiratory, care unit, and the county hospital. And it spread more rapidly through the French hospital because of the ultrasonic nebulizers and such. So sometimes with these disorders, you're better off in the county hospital. You're better off in Elvis than Mount Sinai or NYP.
Okay. Thank you very much. Dr. Camins, from your comments, I understood that, those more sophisticated masks that we used to talk about in epidemic prevention for pan flu, the N95 masks, they're not really relevant in this situation. And further, that with respect to the general surgical masks, there's really no value in prevention other than if you're actually sick, you ought to wear one and to prevent transmission. Much has been spoken about shortages of a whole host of things, not necessarily in the U.S. I personally received phone calls from friends, basically not quarantined, but told to stay home in Beijing, Shanghai, and talking about significant shortages of masks and all sorts of things. What's going on here with respect to potential supplies of these things? Do you feel that we are pretty resilient in that respect? And are we actually stepping up and doing what we can to help supply some of our some of the folks and helping stem the spread in China by shipping supplies and materials?
So I have seen reports of at least other countries supplying or shipping supplies, right? But there actually are issues. So one of the CDC recommends that if you're a healthcare worker and taking care of a patient with the novel coronavirus, you actually have to put on an N95 respirators. So as much as we try to stockpile as much of it as a health system, the current demand is outpacing the supply, right? And again, the manufacturers have also funneled them to regions with active cases. So the good news about New York is that, at least the last time I heard, is that they had one still pending of a patient under investigation that they probably, since we haven't heard today that was positive, chances are it'll probably come back negative. But again, because we haven't had a case, the supplies are not being funneled towards us. But we've learned a lot with SARS, with Ebola, with even MERS, that even our public health institutions have actually stockpiled supplies as well. So I think that the requests and from healthcare workers or like us is to say, we're trying in Wuhan, because the chances of having a positive patient is high, they're wearing masks even on the streets, right? But in areas where there's low risk for spread and we don't have that many cases, we should save those masks for healthcare institutions, because if someone were to come into the hospital because they have to, we would put a mask on them first so they don't spread it to our healthcare workers. But really the answer would be if you are not that sick, you would then just stay at home, just like we would say with the flu, so you don't get anyone sick. So the mask is the second choice, right? The first choice is really stay at home, right? And don't infect anyone else if you can. And the second is if you were to go outside or go to a healthcare institution, ask for a mask, because then we can we can avoid people from being infected.
Great, and on that topic, we have a question from Dr. Ken Lankin, who's the medical director at JP Morgan. And he asks, we heard the message pretty clear that the N95 masks are not recommended for the general public. What can we say about the quote, dust masks, the type that the construction workers might wear? Our sense is they are not of any help for infection control. What do you think?
Actually, they are, if I'm not mistaken, they're N95 as well. So they probably will work, but the same thing about construction workers, the OSHA guidelines for fit testing is the same for construction and in healthcare. In fact, if you actually go look at the original regulation, it's actually for construction. Healthcare is just other. It actually doesn't say healthcare specifically, but construction is on there as.
But if they are not fit tested, then it's...
Right.
That's still
Right.
the same thing. The
It's
same
zero.
thing. Right.
Okay.
Even construction workers actually have to go through
Fit
fit testing.
testing.
And I just want to add, as you have mentioned, if you've ever worn an N95, you're just not going to stay in it more than 15 minutes.
Right.
You just aren't.
Right.
It's suffocating. So as a practical consideration.
Okay, so I have a question for Ms. Russell. We've had some discussions about some of the questions that you've heard.
Yes.
Some of them are pretty embarrassing.
Yes.
And your remarks were quite formal. And I think we have a group of very engaged clients on this webcast. And sometimes you have to kind of open up a little bit to give people permission to ask what they may think is a stupid question or an embarrassing question, but feel uncomfortable about asking. You deal with this a lot. You have given us informally some of the samples of questions that you've had, and why don't you just take a couple of minutes and go through the kinds of things that people ask that we shouldn't be ashamed of asking, and the kinds of things that some of the folks on the phone, if they can take your advice on how to best respond. Again, the goal here is to open up a little bit and really talk about some of these issues that are on people's minds, but sometimes really afraid to vocalize.
Sure. I think as long as we're calling this a global health emergency, as long as the numbers are going up, people are going to be afraid. They're going to have fear, they're going to have anxiety, they're going to have concerns. And I don't think you can diminish in any way the kinds of questions you may want to anticipate. And you want to be prepared, so maybe research scenarios, maybe think ahead in terms of this. So what are some of the questions that we're hearing? Well, for travelers, we are hearing, is it safe to go through an airport? Any airport, because people come from all over. Should I be wearing a mask? The mask question is going to come up every single day, no matter what we say here on this panel or what is said by CDC. With regards to the workplace, I would encourage you to have a policy so that at least there's a few masks in case someone says, Joe over there is coughing. I think he traveled, 2 months ago to Africa, but I'm concerned, and you're then able to proceed with the State Health Department guidelines for isolating him in a room. The door is closed, and you can proceed. I would encourage mask security. I would encourage security for this, too. If you start passing these things out, there's going to be hoarding. There's no question. My local Walmart, believe it or not, ran out of masks, okay, because people were going in and buying large quantities. Other questions are going to be things like, can I stay home? This is just too upsetting for me. You may find that employees who have not revealed underlying chronic health problems, immunosuppression issues, employees who are trying to get pregnant, are pregnant, haven't described their pregnancy, they are having heightened anxiety and their concerns. So there may be a need for you to be looking at your policies around absences and flexibility of work arrangements. With regards to travelers, again, there is concerns about, they say disinfect your surfaces. Well, people are saying, does that mean I take a wipe and I wipe off the seat? I wipe off the tray? Is that sufficient? It really is critical to define these things operationally and in very clear detail. Yesterday's New York Times did a great job, a pediatrician out in Indiana, describing hand washing. Now, hand washing is not that. That is not hand washing. Hand washing is wetting your hands, soaping up your hands, and singing happy birthday twice, either out loud if you're good or in your head if you're not such a good singer. That's hand washing. Workplaces have to have readily available places to wash the hands, or failing that, the 60% alcohol hand sanitizer. Coughing etiquette. People wearing suits are going, I'm supposed to really sneeze or cough into my jacket? Yes, that's what you're supposed to do if you don't have tissues. So maybe adequately supplying your employees with tissues so that they can properly use them, and then directing them to wash their hands. These are things that we know work for flu. These are things we know work for other respiratory infections. These are things we want to promote now for this viral outbreak.
Great. I have a question from Sherry Dean, the VP of Human Resources from Hovnanian. If an individual who returned from one of the infected areas and are self-monitoring, they should not interact with others during this period, correct? Well, I can ask Dr. Lipkin that. Are you interacting with anybody over there, or are you in complete isolation?
We're interacting right now. Electronic media. No, you're not supposed to be interacting with anyone. That's the point of the isolation. Is it perfect? No. But my family is on a different floor. I'm in the basement for the most part.
I'd like to add that there were comments this morning from Brighton in England where people were saying, well, this is fine and good, but then I need to know how to get food. I need to know how to get medicines. I need to know, does this mean I can't go to my daughter's only ballet recital? I think self-isolation needs to be very, very clearly defined for individuals so they won't say, well, you know, I had to run one errand, I'm feeling perfectly fine. It does mean what Dr. Lipkin just described. He's sitting there alone in this room and not contacting others.
Yeah, so I have tickets, for example, for David Byrne tonight.
Okay.
I can't use them.
Right.
This is really, and it closes.
Only worse if it was
And
Hamilton,
it
right?
closes on the 16th, you know, so yes, it's painful.
Yes.
So for Ms. Russell, here's my next dumb question.
Okay.
So
No
somebody,
dumb questions, remember?
somebody comes back and they're in self-isolation, but their whole family, you know, has to move, or they have to go somewhere, or maybe, I mean, clearly not a hotel. I mean, they want to be in self-isolation, and they've been on a business trip coming back. Should the company pay for their self-isolation? I'm sure people have asked that
Right,
question
and I
before.
think that's an excellent question for every one of the listeners to be asking within their organization. What are they going to be doing for these individuals who had a work-related trip that has now resulted? And I'm sure there are benefit people and risk management people and workers' comp people on the phone, and that's an excellent question. Some companies have very liberal policies with regards to work-related episodes. Others want to define it more narrowly. But I know you'll get that question. And I think it's a question that will have to be decided by each company.
By each company.
By each company, yes.
Great. I have an anonymous question. When traveling, maybe Dr. Camins can answer this. When traveling via airplane, should you turn on the air on or off at your seat if you are trying to avoid getting sick? And why don't you throw in the mask while we're
That's
at
right.
it?
So again, I think we're going to repeat it, right? The mask doesn't help unless you are the person sick,
Okay,
right? So if you are sick, please don't travel, because then you will probably cause a panic on the plane. The good news about it is actually, for most of the new airplanes, they are actually recirculated air, but it's HEPA filtered. So unless I looked at the CDC guide for how to judge who was exposed on the plane, if you are, I think it was 2 seats.
It's 2 seats in each direction.
So if you're 2 seats in each direction, for example, there's no reason to worry about it. And the CDC won't even count you as probably an exposed. But mind you, we still don't know, right? But certainly that's the guidelines they put out. Again, if everybody were thinking about everybody else, the golden rule, will have less issues, right? So meaning, if someone who's sick, who has symptoms, doesn't step on the plane, it will make the trip a lot better. But again, I'm a germaphobe, so I actually wipe everything down that I can wipe unless it's fabric, but I bring my own. But again, I did that because of E. coli and flu before coronavirus, right? Because there have been reports and they swabbed these tray tables. There was a lot of E. coli because they never wiped them down. But again, that's my personal view, but I will not put on a mask. I'm flying to Europe in about 2 weeks and I'm yeah. So it's scary, but you can't be a nomad. I mean, you can't just, lock yourself in your apartment either. So.
How do you tell, Dr. Camins, if you're on one of those planes that have that filtration? Is there?
I don't think that there's.
Did you ask the pilot when you get on, or? No, I'm serious.
I think if it's
How do you tell?
I think
That's pretty much the
right.
standard
Right.
now.
It is the standard.
It is. Planes, for the most part, have much
Okay.
better air circulation than most offices.
Yeah, I agree, because it's HEPA filtered.
Yeah.
Okay, so the next question I have for Dr. Lipkin, from Jorge Verlade, who's the Chief Financial Officer at JBADH. Is it true that they are realizing that the incubation period is more than 14 days?
The incubation period is very difficult to estimate. We know that based on a recent report that came out of the largest clinical group, study of 1,000 patients, the incubation period was at a median of 3 days. And most of us anticipated a range 5 to 7 days. The challenge with some of these estimates, which are longer, is that one cannot exclude the possibility, in China, for example, that you met somebody, weren't aware, say 5 days before you presented with signs of disease. And all you recollect is the 20 days earlier. So unless we have epidemiological data from individuals who only have a possibility of exposure at a single time point because they're traveling through an airport in China, they're there for 1 day and then they go someplace else, it's very difficult to know what the answer is. I certainly hope that they don't extend me for another week because I'm going out. So I think that 14 days is already, I feel it's excessive. Okay?
Yes.
I think most people would say twice the average incubation period is fine. So 10 days should be sufficient, but that's not the current guideline and that's the one we have to live with. I would say, to address the earlier question concerning whether or not you're responsible for an employee, if you send an employee into an area and she comes back and has to be in isolation, you have a responsibility.
Mm-hmm.
You can't walk away from that. And the last thing about masks I would say is I appreciate that everything we said about the N95 masks, surgical masks and so forth, but if a mask prevents you from putting your fingers into your mouth or your nose, it probably has some value. So what I tell people is it's sort of like shoulder belts and seat belts. You get into an old car, doesn't have a shoulder belt, probably it's a good idea to put on the lap belt. So it's equivalent of a lap belt. Does it work well? No. Does it discourage some people from touching their nose and their mouth? Probably. And you can teach people how to wear them.
But the only caveat to that, right? Sometimes when you have something in your face, you start scratching it, right? So then you're more likely than to go underneath the mask and scratch your nose. So again, it's both ways. But I think and
we know how often we actually touch our faces. I mean, it's extraordinary.
So the only thing I would say, if there wasn't a shortage for the healthcare workers who will be working, or at least in the healthcare industry, or even in China where they really have an issue, I would say, I think we could have a different message. Go do whatever you want with your mask, but I think there are issues where we're running short, because even we were very generous about it, but we've had some visitors just grab 10 or 20, right, our whole box.
To the hospital.
Yes, sure. At our entrances, because we were very good about that because of the flu. But we saw that our demand went up 3 times.
Right.
And it wasn't, it wasn't because there was a huge flu outbreak, it was because there was coronavirus on the news, so, yeah.
And I just want to add that, I'm always just concerned that when you use one means versus another, then they'll forget the basics, like hand washing. It's like, well, I'm wearing the mask, so I don't really have to, or do the social distancing, or stay home when sick.
Dr. Lipkin, could I just, a follow-up question on the transmission is early on, there was a point of view that you had to be symptomatic to transmit. Then there was a suggestion that there was lots of asymptomatic transmission going on. In the past few days, we've seen that that's largely been, or potentially been, refuted. What is your sense of the transmissibility? Or can people transmit without being actually symptomatic?
I think the evidence is that you can transmit when you're asymptomatic. There was an article that appeared in the New England Journal about a woman who had passed through a city in Germany. She'd worked with various coworkers. She had gotten onto a plane and she was asymptomatic, and the people with whom she was working subsequently became ill. This was the argument for asymptomatic transmission. Then we found out she was on antipyretics and she had some back pain and a few other things. And so she really wasn't asymptomatic. So but there have been other cases where people have very mild symptoms, which may appear like being asymptomatic, and they transmit. So I think we have to err in this case on saying that they're asymptomatic transmission. I'm consulting for one very large company, which is talking right now about whether or not they want to do prophylactic, diagnostic NP swabs.
That's nasopharyngeal swabs.
Mm-hmm. No.
And
Yeah.
so,
Okay.
We don't know the answer to your question. Sorry.
Okay.
So, Ms. Russell, I have a question.
Yes.
I have a question for you from Wendy Boyce. If I am flying to Japan in March,
Yes.
what precautions should I take, or should I cancel the trip?
Right.
And I would just add to that, what would you do?
Yeah. Well, I spent most of Sunday, people going to Bali in June, people going everywhere. This is the question on everybody's minds. Right now, the recommendation I'm making to people is, one, any chance that you've purchased cancellation insurance, if you have, that's going to be your backup. This is evolving. Dr. Lipkin just said this could very well not peak until the beginning of April. Personally, a couple of weeks ago, I probably would have said I got on the plane. Now I would certainly wait till closer to the time of departure, but anticipate that things may evolve such that the answer will be quite obvious to this individual.
Okay. There's another question, John?
Yeah, I'm just going to read it. This is
But
from,
they can't hear.
this is from Jennifer Chalupa. Can they find a better test than a nasal swab, which, with all the technology and resources, we would like to have a better and less invasive test?
And Dr. Camins, maybe you can answer that. The question is there a better and less invasive test than nasopharyngeal swab?
It does cause people to sneeze or cough or gag sometimes with the nasopharyngeal. But I think that is less invasive than doing a blood test, right? And the problem with that is that it's not necessarily that people become viremic, and correct me if I'm wrong, Dr. Lipkin, is that with coronaviruses, sometimes you actually may not find it in the blood, but really find it in your nasal passages and your oral. So the CDC is asking for oral swabs as well, but in the same token, if it's a virus, the best way to diagnose flu is through a nasopharyngeal swab. So I think we have to do it only because we want to make the tests work better. So sampling error could happen where you have a false negative if you actually don't get the right specimen, right? So right now, with most respiratory pathogens or viruses, we actually need to do a nasopharyngeal swab. So that's the best answer I can give. Does that make sense? So
Yep,
you want to have the right test, or else you have a false negative. So
Okay, so I have the last question, which is a perfect segue into closing out the discussion today. And it says, when will EHE be providing resources to clients which we can then distribute to employees? So the answer to the question is, well, first of all, that this webinar is our first step in communicating with our employer clients and thinking about how to then move ahead and talk to our employees. This is not quite the same thing as talking to everybody about a measles epidemic, and it's not quite the same thing. So I think that in terms of a mass public communication, we're not going to jump out there without having a little bit more discussion with our employers. That said, we have updated and educated all of our own physicians in our system, as well as our internal ones and our networked ones, with respect to what the latest CDC recommendations are. We have already implemented the CDC recommendations, which every single patient who comes to any of our own facilities or facilities belong to our network physicians are going to be questioned in advance to see if in fact they have been to one of the areas within the past 14 or 15 days to implement the CDC recommendations, or if they have been in contact with somebody with a suspected flu. Starting on Friday, we are opening a 1-800 line, which in fact is for both employers, clients, people in the benefits department or whomever, as well as patients, and that line will be manned by our specially trained travel nurses who have access to the Travex database, which is, it's called the Shoreland Travex program, which is a fairly sophisticated database, which really gives up-to-the-minute information on exactly where the epidemic is, what's happening. So we have purchased and licensed tools to follow this very closely. The 1-800 line will be open during business hours, but because obviously in this situation there's an email address, if nobody answers the phone, we will be monitoring the email address, the email box continuously 24/7 and to get back as soon as possible. So that's what EHE is doing. And I think when we get some feedback from some of our clients, we've actually discussed whether this merits perhaps revisiting this in the next couple of weeks to see where this thing evolves. So I just want to take a minute to thank everybody, to thank our distinguished panel. I found this incredibly interesting and useful. I hope our clients felt the same way. And of course, if there's any further questions that any of our clients have, or any of you, I will pass them along and we will get them answered directly. So thank you very much again for everybody. Thank you all for joining, who joined on the phone, and have a good rest of the afternoon and in good health.